To celebrate our last face-to-face class today, I'm going to begin by giving you this gift, which summarizes for you the breakdown for Test 4. So when is Test 4? 2 weeks from today, right? Next Thursday you're off eating turkey or whatever. In 2 weeks we do 20 questions on the psych disorders, 11 on treatment, which is what we're going to cover today, and probably finish up online on Tuesday, if the 8 o'clock session is any indication. And then we'll move into social psych on Tuesday, finish that up the Tuesday after Thanksgiving online, and then again the test will be 2 weeks from today. So 9 questions on social psych. So 20, 11, and 9 is the breakdown. I told you that on the front end, right, that you needed to overemphasize the psych disorders. If you have a good sense of those, you're going to be in good shape for test number 4. Let me make a couple other announcements and then see if you guys have any questions. There's been some confusion around the clicker point totals that are showing up in Blackboard and all that. So at this point, there's a running total in Blackboard that has said unofficial all semester long. It's basically every single session we've done so far. We've done 9. Today will be session number 10 with the clickers. When we're done today, I will do the official computation. And the official computation will involve selecting 8 of those 10 days, and those 8 days will add up to 100 points. Included within every single day's points is the 5 points for attendance. So it's not separately broken out. You won't see a separate column that says 40 points worth of attendance, another column that says 60 points worth of questions. It's all together. Okay? So if you had a class session where you got 11 points, that means you got 5 for attendance and 6 for the clicker questions. Okay? So I'll have that totaled up probably by the end of the day today. It's pretty easy for me to just do that grab of 8 of those 10 days, and that official total will show up. Then you'll have a course total in Blackboard that will consist of Test 1, Test 2, Test 3, official clicker points, and then if you had the 7 points of extra credit. That's your total from Blackboard. And remember, over in Psych Portal is where the learning curve activities live. That point total is in there. You could just add all those up. Remember, it maxes out at 120. Okay? I may ultimately create a column in Blackboard where I transfer those points over. If I could create enough time to do that, I'll do that. Probably not over the break for Thanksgiving, but maybe after we get back. What else? Oh, the other thing I just wanted to remind you of, remember, you had last Sunday off. If you do all of your learning curve quizzes on Sunday night, you've got 2 chapters worth due this Sunday, which is right before you head out for Thanksgiving. So don't forget, psych disorders and the treatment section are both due this Sunday. And then social psych is then a week and a half away. It's on the Wednesday night at 11 before we take the test in 2 weeks on that Thursday, the 5th of December. Okay? Same thing for test 4. You got to show up by 9:55. If you show up later than that, you'll get a 0 on test number 4. That's everything I could think of. Questions that you guys might have about any end of semester administrative or housekeeping things? Yeah. So learning curve points either will go into Blackboard at some point before we're all done, or they won't. And if they don't, what I'll do is I can download the Blackboard gradebook into Excel. I can download Psych Portal into Excel, and then I kind of weld them together. The only headache with that is, you guys only need to worry about this, the 2 rosters don't line up perfectly. So that's kind of a headache, because there will be some people in Psych Portal who drop the class and are not in Blackboard. So I've started going and just basically manually entering them in Blackboard. That's what I did in the spring, and it worked fine. It didn't take incredibly long. So if my kids will leave me alone for like an hour, I can do that. Research participation is a departmental requirement. It's not for any points other than if you had 2 done by the midpoint, you got the 7 points, and those are in Blackboard. But that is not for any additional points outside of that. Okay? Anything else? All right, let's talk about treatment. In the first section, I had anticipated getting farther than I did, but I didn't get there, whatever. We have plenty of time to finish what we need to finish. So let me give you the outline here, just verbally, for this treatment section. First thing we're going to do in the first 20, 25 minutes is talk about 4 different types of biomedical therapies, that is biological treatments, which have as their goal changing something in terms of brain functioning. Okay? So we'll talk about 4 biomedical therapies, and that will include medications. We'll talk about medications that can be used to treat things like depression, and those medications actually are often used as well for anxiety. After the biomedical therapies, we'll talk about talk psychotherapy. So we'll talk about Freud, Rogers, Aaron Beck, and Joseph Volpe. 4 different approaches to sitting down and talking with you to help you get less depressed or less anxious or whatever the case might be. The third segment in treatment is on treatment outcome studies. How do we design them? And then now that they've been designed and run, what have they found about the effectiveness of these different treatments we're going to talk about? It's likely that we won't get to that because we spend a lot of time talking about the different treatments today. So we'll probably finish up treatment outcomes in the first 15 minutes on Tuesday, at which point then we'll launch into the section on social psych. We'll do 3 clicker questions near the end. In the 8 o'clock class, we just use like the last 10 minutes to do like a little quiz together, basically on what we talk about today. So we'll do that and save those for the end, and that worked just fine. So let's talk about these biomedical therapies. Oh, I didn't even start a clicker session. That would help. It must be the last day of class because I'm forgetting to do basic things. Let me go here and find what I got to find. No, that's not it. So you really won't need your clicker turned on until the last 10 minutes or so. So if you've got it, great, but don't worry about getting it fired up yet. Was it raining as you guys came in? No, a little drizzle here or there? All right. It's nice just to have something different other than just sun constantly. All right. Not that that's a bad thing. All right. So biomedical therapies. These are the 4 we're going to discuss together. Psychosurgery, something called ECT or electroconvulsive therapy, something called RTMS or repetitive transcranial magnetic stimulation. And then finally, the drug therapies is basically going to be a discussion of medications. And as I mentioned in passing on Tuesday online, I'm not going to give you a giant list of medications to memorize and the different disorders for which they're used. I'll keep it simple, and we'll get to that in just a bit. So psychosurgery literally is brain surgery. And I want you to think about this as a treatment of what I'm going to call last resort. And a treatment of last resort means it's a last-ditch effort to treat some kind of disorder. And the 2 disorders for which psychosurgery can be used that we've talked about are OCD and depression. Good Lord. I'm having the hardest time writing up here with this mouse today. So depression would be the other one. So what does it involve? It involves brain surgery. It literally involves opening up your skull, going in there, and maybe severing connections between one part of your brain and another part of your brain. It might involve going in and cutting out a small part of your brain, etc. It's a treatment of last resort, which means it's the Hail Mary pass at the end of the football game, right? When all else has failed in terms of talk psychotherapy, medications, probably for years and years and years, you might, as a last-ditch effort, turn to psychosurgery. It's much more refined today than it was 30 or 50 or 80 or 100 years ago. So we've got much more precise instrumentation. The technology is there to let us go and intervene specifically how we want to, right? If you want to think about psychosurgery, the HM case study in the section on memory, that was psychosurgery, right? That was a brain surgery that involved removing some parts of his temporal lobes. Having said all that, I'll tell you that I don't think I've ever encountered a case where somebody actually opted for psychosurgery. So it's extremely rare. On the list of treatments that could be done, this is the one that's probably most unusual. You're not going to see this done much at all. ECT number 2 is what's depicted here. The guy in the colorful, almost Christmas-looking boxer shorts here. He's got stimulating electrodes connected to the top of his forehead, right on the edge of his hairline there. Okay, he's got 2, so this is called bilateral ECT. You could do unilateral ECT if there was one stimulating electrode. This is the device that's going to be used to deliver the shock. We're going to be monitoring his heart rate, Very importantly, especially in the context of the history of ECT, we're going to be using an IV line to deliver sedatives and muscle relaxants. Why? Well, because ECT is going to involve the delivery of electricity to his brain. If you shock the brain, what might happen to this person physically on the table? What are they going to do when you give them that jolt? I just saw people kind of jumping, right? An epileptic-like seizure where the person could be flailing about. And actually in the history of ECT, early on, they didn't realize the power of the flailing around that would occur. People would go flying off the treatment table. Okay? The solution for that was then to try to use restraints. Let's sort of strap them down, tie them down, so that they won't go flailing off the table. What happened then was if you overdid it with that and they were moving real strongly against each, you could dislocate elbows, dislocate shoulders, break collarbones, wrists, etc. Okay? So what we do now is we use these sedatives and muscle relaxants to make what's apparent on the table to you as you observe ECT look like not much of anything at all is happening. Okay? Because they're so sedated and the muscle relaxants are so strong that when the jolt of electricity is delivered, you don't see them sort of jumping around, moving around on the table. Okay? You won't need to label anything in a diagram like this. I just wanted to give you a picture of what this looks like. What happens is electricity is passed through those electrodes up top for typically about a half a second. So it's sort of like rebooting the brain here in some ways, right? The result is an epileptic-like seizure, which, as I said, is a lot less visible to you as an observer of this versus what it was before. After the half a second of electricity, there'll be that seizure kind of response for anywhere from maybe 5 to about 30 seconds. Okay? After that is over, anywhere from maybe 5 or 10 to as long as 20 or 30 minutes, the person will be in a kind of a coma-like state. They're lying there and they look like they're completely out of it and completely unconscious. Okay? They come back around after that point, and typically this treatment is done 6 to 10 times over the course of a couple of weeks. So we might have this, every day or every other day over the course of a couple of weeks. It was originally tried with schizophrenia. It was found not to be very effective for people with schizophrenia, and now it's used again as a treatment of last resort for severe and very treatment-resistant depression. Okay. In other words, if you went into a mental health clinic today and reported symptoms of depression, and they diagnosed you as having major depression, you had more than 5 out of 9 symptoms, and one of them was number 1 or number 2, they're probably not going to say, hey, we should go plug you in and give you ECT. Okay? What they're going to say is probably we should try some combination of medication and talk psychotherapy. But if you had a very severe depression and it lasted for years and years and years and years, you might ultimately opt for ECT as a treatment. Okay? For the 30 to 35% of folks who don't respond positively to medications, ECT looks like it helps about 2/3 of them, which is actually pretty good if you think about it, right? So the segment that doesn't get help by medication, a significant chunk of that segment is going to benefit from ECT. Drawbacks are obviously the seizures. Another drawback with ECT is we don't really understand why it works. It's not like it specifically increases serotonin levels, right, which we know are implicated in depression. It looks like it increases neurotransmitter levels across a number of different neurotransmitter systems. So the mechanism of action is not real clear to us. Probably the biggest drawback to ECT for folks is after treatment, what you can get is some memory loss. And the memory loss is for the period of time prior to the treatment. So let's think about what kind of amnesia that was, right? So we get the treatment today, and let's pretend I don't remember anything since Halloween. 3 weeks worth of that kind of amnesia. What kind of amnesia was that? Retrograde. Good. It's still in there somewhere. Good. So retrograde amnesia is kind of a side effect here of this treatment. Okay? Now, if you think about that for a second, you could be like, well, maybe that's why you're not depressed when you come out of this, because you totally forgot why you were sad. But that's not why it works. Okay? But it clearly changes some things biologically here. Again, the precise mechanism of action we don't totally understand. Okay? This is not incredibly widely used, but it's certainly much more often used than psychosurgery. Okay? Questions on those first two of the biomedical treatments? Make sense? Okay, you have to just recognize. Yeah, question. Say again? To go forward and have problems with memory? Generally not. So our question was, could you have sort of persistent memory problems after this? Right? Maybe could you get like anterograde amnesia where like Dory, you can't form new memories you're having? That's generally not found. That would be very unusual. And I suspect that that was going on. There might have been some underlying hippocampus problem that we didn't even notice before. Okay, so generally that doesn't happen. Let's talk about this third one. RTMS is the catchy little way of abbreviating it, giving it a little acronym here. It's repetitive transcranial magnetic stimulation. So what does that mean? It means we're going to deliver pulses of magnetic energy to the brain. This looks like something from Saturday Night Live or something. It's not really a joke. This is a real treatment. This wire coil is placed over the top of your head, and via the wire coil, we deliver bursts of magnetic energy. Okay? What's the idea here? The idea is to try to stimulate the brain. What I find fascinating about it is that the depth of the penetration of these magnetic waves is pretty shallow. Right? It only goes kind of to the overlying cortex. It doesn't penetrate down into a midbrain structure like the hippocampus or the amygdala or something like that. So in some ways, just to help you remember this, I would say this is in some ways similar to what we talked about when we discussed the EEG. Right? Remember the EEG did a recording of activity at the level of the overlying cortex? Well, this isn't recording. This is actually delivering these magnetic pulses to the brain. Good thing with RTMS is that it's a painless procedure. It's performed on you while you're awake. So basically you kind of, position yourself with this frame, your forehead here, your chin resting on that thing down below. Unlike ECT, RTMS doesn't produce any seizures. It doesn't produce any memory loss or any other kind of side effects. And it is also used to treat depression. So if you get stuck on the test, and there's a question about a biomedical therapy, and it asks which disorder it's used to treat, what's your best guess? Depression. Okay. Why is this? Well, think back to the lifetime prevalence rates, right? Lifetime prevalence rates for depression were so high, we come up with lots of different ways of treating this disorder because the prevalence rates are so high. We called it the common cold of the mental disorders. RTMS, in terms of mechanism of action, you might be wondering, how does it do what it does? Why does it work? It looks like what it does in particular is it increases activity in the left frontal lobe. Turns out that for some reason in folks who are depressed, this left frontal lobe is relatively under-aroused. This RTMS seems to sort of give that a jolt, a burst of energy, if you will, making that left frontal lobe a little more active. Okay. Treatment outcome studies have been positive to date. There are some larger multi-site studies being done now. I think this is going to become a more common treatment. I think partly because it feels a little less intrusive than the ECT thing, right? This, you've got all this medical stuff going on, and you're being sedated, and here you are, you're just sitting your head in this frame, and they're doing this thing over your head that's working, okay, in terms of delivering those magnetic waves. By the way, thinking about research methods for a second, if you had to run one of those treatment outcome studies, this is what you do with the treatment group. What would you do with the control group so that you could determine whether the magnetic pulses actually decrease depression? I'd set them up like this, and what would I then do? Not deliver those pulses, right? So I probably had to have some kind of noise, saying like, whatever, something over here that made it sound like something was happening, but really nothing was truly being delivered. And that's, in fact, how they run those studies. Okay? Any questions about RTMS? It's pretty new. That's within the last half dozen years or so. That's why I had to look a little more closely at my notes because I don't know that one as well as I know some of the other stuff here. All right, let's talk about the medication. So the drug therapies is just a fancy way of saying meds here. As I mentioned before, we're not going to look at a giant table that lists, 30 35 different medications for all kinds of different disorders. Let's just focus on the antidepressant medications that are used to treat depression. Okay? And one of these classes, called the SSRIs, which we mentioned last week, and I think we even mentioned last week in here, can also have anxiety-reducing effects. So when I talk about them here as antidepressants, remember, they could also be used for something like GAD or something like that. So there are three major classes of antidepressant medications. They're called the MAOIs, the tricyclics, and the SSRIs. Okay? I'll sort of give away the answer on the front end here by saying that the most commonly used among these three classes of antidepressants is the SSRI group. What's interesting about the SSRI group and why they're so widely used is not that this medication class is any more effective, because overall the effectiveness rate across all three classes is basically about 2/3, 60 to 70% range. Sometimes you'll see it creeping up into the low 70% range. Okay? So the SSRIs don't necessarily work more effectively, that is, decrease depression more than the other medications. So why are they so widely used? Mainly, they're more widely used because their side effect profile is much better. Okay? They're better tolerated by people that are taking them. Okay? And one of the reasons why people don't take medications is because they get bad side effects. So if you can find something that works just as well and doesn't give you the bad side effects, people are going to be more likely to take it. So let's talk about the first two, and then we'll get into more detail on the SSRIs. The MAOIs, the monoamine oxidase inhibitors, are medications that actually affect both serotonin and norepinephrine. So these top two actually have a little bit more of a diffuse effect on two different neurotransmitter systems. So these guys are going to affect both serotonin, and I'm never going to fit norepinephrine down below, so I'll just write norep. That's another neurotransmitter that we didn't spend a whole lot of time talking about. Okay? How do they do what they do? The MAOIs are interesting. What they do is they inhibit something. Well, they're monoamine oxidase inhibitors. Basically, here's the idea. Monoamine oxidase is kind of like Pac-Man. And let me run with this for a second. It metabolizes the serotonin and it metabolizes the norepinephrine. Okay? So it goes in there after the neurotransmitter is released and it binds to the receptor site, and then it goes back into the synapse. Usually what happens is this monoamine oxidase comes through and breaks down and eats up that neurotransmitter. Okay? If you inhibit that, what's the net effect on the amount of serotonin or norepinephrine in the synapse there? If you don't let this guy eat them up, what happens? There's more of it, right? So we increase serotonin levels through that mechanism of action with the MAOIs. Okay? Big drawback to the MAOIs include side effects. I mentioned that before, but that can include headache, dry mouth. People will complain about gastrointestinal side effects, constipation, decreased libido, all kinds of different things like that. Okay, with the MAOIs, and again, to a greater degree than you get with the SSRIs. The other issue with the MAOIs is dietary restrictions. And basically, there are a lot of awesome things that you could eat or drink that you're not allowed to eat or drink when you're taking MAOIs. It's basically anything that would happen to Oktoberfest. Red wine, pickled products, sausage products, cheese, probably most importantly, chocolate. Like, there's a medication now you can't eat chocolate. I mean, you're already depressed, and now you've been told, and now you cannot eat chocolate either. It's like, kill me now, right? There's no point to living if I can't have my chocolate. All right, so we move away from those often because of that. And actually, the other issue with MAOIs is if you just look at a bunch of your over-the-counter medications for whatever, a lot of them on the warning say, if you're taking MAOIs, check with your doctor, because it could make something funky happen. So that's the issue there. Tricyclics, again, affect serotonin and norepinephrine. Again, they're more hampered by the side effects that they cause, and so consequently, we use SSRI. So if you don't have in your notes a list of these, examples would be Prozac and Paxil and Zoloft. Those are all SSRI medications that you almost certainly have heard of. The other medications that have come out in the last, it's got to be 10 to 12, maybe 15 years now, is besides the SSRIs, you actually now have SNRIs. which are selective norepinephrine reuptake inhibitors. So kind of the same way of doing it in terms of the mechanism of action, which we're going to describe in a second. It's just they're affecting norepinephrine instead of serotonin. So the SSRIs do what they do because of this. So let's take a look at this slide, and I like this because it makes us remember the bio and show you that bio wasn't just for the hell of it. It's directly related to things like depression, or again, you can use SSRIs for anxiety too. So messages sent across the synapse, right? Chemical between. We've got synaptic vesicles releasing neurotransmitters, which are then binding to receptor sites. And usually, after that occurs, when the message is received, those neurotransmitters, the little yellow balls here, the serotonin in this case, it will be kind of vacuumed back up. This reuptake process is basically a vacuuming up process whereby they're the return to that presynaptic neuron. Right? We're sort of reabsorbing them via reuptake. Here's what Prozac does. The little red kind of cubic squarish things here. They block and stop that reuptake. Right? So selective serotonin reuptake inhibitors. They basically turn off the vacuum. If you turn off the vacuum, what happens to the amount of serotonin in the synapse? It increases, right? So the net impact is more serotonin bathing the synapse here for longer periods of time. Seems to have not only a mood elevating effect, but actually, as I said before, can be used to treat anxiety as well. It's not instantaneous. These are not happy pills. Okay? What's weird about these medications is the biochemical effects will occur within something along the order of a number of hours. So there'll be changes to the synapse really quickly. But clinical effects in terms of your symptoms going down can take 2 weeks, 4 weeks, 5 weeks. Okay? So it's not an instantaneous thing. And that lag, by the way, is what makes me believe, or at least sort of logically reason through, that the depression can't be just the neurotransmitters. Because if the neurotransmitter changes occur in 3 to 5 hours, let's say, why might it take me 3 to 5 weeks to feel better? Right? So obviously feeling better goes beyond just what's going on at the level of the synapse. Right? There are other factors involved. That's where the other kinds of behavioral and cognitive factors play a role. Yeah, go ahead. So basically, Wellbutrin I don't know specifically myself real well because I'm not an MD, but what they do is they basically modulate neurotransmitter levels. So if it's affecting dopamine, it could be doing something to increase dopamine levels or decrease it. If we go back to schizophrenia, right, what do we say schizophrenia is what? Too much dopamine. What I want to do is decrease that. I would use some kind of medication that would reduce dopamine levels to help with the psychotic symptoms, right? The hallucinations, delusions, and all that. Wellbutrin, where would I put it in the category? I would have to look it up, to be honest. I don't even worry about the medication stuff because the MDs deal with all that. But it's something certainly to monitor and know something about. I think the thing with the SSRIs, especially in the context of depression, is, we mentioned this last time, right? Suicidality is one of your symptoms of depression. So when this, starts happening as a treatment, you need to be aware of monitoring levels of suicidality, right? I wouldn't want a primary care doc to throw some SSRIs at you and say, see you in a year for your next checkup, okay? Because if you have major depression, one of your symptoms could be suicidality. And if I didn't mention it last week, I'll mention it here. The issue with suicidality is actually not so much, remember I drew the trough? When you feel depressed, it goes down like this, your mood. The biggest risk for suicidality is not actually when you're at the bottom of the depression. You know why not? When you've got that much depression, you don't even have enough energy to go and kill yourself. Okay? It's actually when you start to improve some, when you start to see the upswing, that we need to be concerned about that, and that's why the monitoring of that in the context of an SSRI treatment is really, really important. I mean, you should be seeing the doctor every week for that first month or two, or at least every 2 weeks. It shouldn't be like, here's the meds, good luck, see you in a year. Okay? So that's the story on the biological treatments. Let me just bounce back, sorry, to this slide. Any questions on any of those? Any confusion about any of that? Yeah. Good question. She said, would you possibly drain out? That sounds awful, doesn't it? I'm going to drain out all my serotonin. No, what happens, and I don't understand the biochemistry well enough to explain it. Basically what happens is, this is sort of a short-term process. It's not like they block this up and make it so that the serotonin can never go back. The one thing that actually is related to this was a big deal when I first started teaching, the ecstasy stuff. What goes on with ecstasy is an increased release of serotonin into the synapse. And the problem with that is the level of that excess amount is so much that it actually does start to, if you continue using that drug a lot over time, it starts to wear out the receptor sites. What happens is the receptors will start to retract into the postsynaptic neuron. That's not good when receptor sites go away. And the second part of that with this ecstasy stuff that's not good with serotonin is one of the other things that goes on is the metabolizing of serotonin by something that comes in and kind of does the Pac-Man thing. And one of those transporters that does that breaking down and removing it actually will can convert this, if you overdo it, into hydrogen peroxide in your brain, which is kind of, you could throw it on your hair. I don't know if you want to throw it around in your brain. So that's another issue there. But yeah, this doesn't last for forever, I guess is the point. All right, let's talk about talk psychotherapy. We got 45 minutes to talk about these 4 brands. We're going to take a look at a video of Stephanie, right? Last week we saw her suffering big time with the OCD. We're going to look at a treatment that's called exposure and response prevention, which is a cognitive behavioral treatment for depression. So this overview slide is intended to let you sort of remember, when you go back in your notes, the big idea. So we've got names here. Freud is psychoanalytic. Rogers does client-centered therapy. He was one of our humanistic psychologists, along with Maslow, doing this sort of very positive, optimistic spin on what makes people tick. Aaron Beck, we mentioned last week when we talked about what causes depression. He was the depressogenic thinking guy. Remember Charlie Brown, assuming that the girls were saying bad things about him, doing that mind-reading thing? That's Beck's work. And Beck's cognitive therapy, not surprisingly, is going to focus on trying to get you to change thinking that makes you feel rotten. And then behavior therapy with Volpe is going to focus on changing specific behaviors. In fact, I should mention here, I know I've got it on a later slide, but let me just mention here, these 2 bottom ones together are so often combined that you're seeing less of an emphasis now on cognitive therapy or behavioral therapy. It's the blending called cognitive behavioral therapy, or CBT. So if you see something about, the treatment of choice for depression is CBT plus an SSRI, now you know what that means, right? Cognitive behavioral treatment plus a selective serotonin reuptake inhibitor medication. So what we're going to do is describe each of these 4. What you're going to need to do, probably on at least 3 or 4 test questions, is be able to recognize a description of a technique or some kind of treatment approach that falls into one of these categories. So I might describe, say, Dr. Smith is doing blah, blah, blah. She has the patient talking about dreams, and she's analyzing the dreams. What kind of treatment is Dr. Smith doing here? Okay, so we'll talk about those. And if you can do that by the time we're done today, you're in real good shape. Okay? Before I start drilling down, I feel obligated to give another LeMakis continuum thing, since we do this all semester long. And the continuum here is going to be, on one end, treatments that emphasize what we're going to call insight. Sort of an aha moment where you have a light bulb go off and you understand something that you didn't understand before. There are going to be some treatments that emphasize that as the mechanism through which you're going to get better. And there are other treatments that say, that is a complete waste of time. You need to go and take action. You need to change behaviors. You need to do more of some things. You need to do less of other things. So where do some of these fall as we talk about them here on the front end? Psychoanalysis, there's no doubt about it, clearly falls onto the insight end of the continuum here. Freud's whole notion is that if you can make unconscious material conscious, okay, and gain insight, and understand why you're doing what you're doing, you'll feel better. And by feel better, I mean you'll feel less depressed or less anxious. So he would emphasize that, right? If you came to him and say, Dr. Freud, I don't know why I always date guys who are jerks. I feel so depressed about it. Every guy I date is a jerk. I hear a couple people relating to that. What's that about? He'd say we need to dig around and gain some insight into why that's occurring, okay, where that comes from. And I'll just make something up and say the insight you ultimately achieve, will say, is you're dating guys who are jerks to get back at your parents because you're mad at them for having your baby sister when you thought you were going to be the only child. I just totally made that up, okay? But that's it. If you just understand why, you'll be less depressed or less anxious or whatever. On the other end of the continuum are the folks that say that insight is just a complete waste of time, and this is where cognitive and behavior therapists clearly fall. They want you to take action, to do something different, right? So here's the criticism. The criticism of behavior therapy is, well, you don't dig around and try to find the roots of the problem. And they're like, yeah, but who cares? Because when you come in for behavior therapy, let's say you've got a phobia, you're coming in because you're afraid of spiders. I don't care why you're afraid of spiders. It kind of doesn't matter, right, on some level. You have this level of anxiety around spiders. You want it to be here. I've got a way of doing that, right? We're going to do a review of a treatment called systematic desensitization from Joseph Volpe that doesn't care at all if that is something that comes from your childhood or whatever, because these guys maintain that doesn't matter. You need to change things, right? Cognitive therapy is going to be about changing the way that you think about things, okay? So stop sort of veering in your thinking to the Charlie Brown and Eeyore pessimistic way of thinking and start thinking in a little bit of a more balanced way. Probably in the middle is where Carl Rogers most likely would fall. And he's a hard one to kind of stick in any specific place because it kind of depends. And the reason it depends will become clear when we start talking about his approach, because his approach is very hands-off. It's very much kind of a facilitator role for the therapist. And so the therapist isn't saying, we're going to work to achieve insight, or we're going to work to do behavior change and take different actions. He's sort of like, it's kind of up to you, and we'll fall maybe somewhere in between and maybe blend those together. Okay? So these are 4 of the major treatment approaches. There are a handful of others that we could talk about, but these 4 cover enough ground to give you some sense. Any questions about that insight versus action range there? Does that seem to make sense a little bit? It gives you some way to think about how they emphasize different things. All right, let's talk about Freud. He is clearly an insight-oriented therapist. His treatment is all about gaining insight. So we've got a nice picture here of a Freudian analysis room. Here's the patient lying on the sofa. He's really depressed because he's a stick figure. Here is Freud sitting on the chair over here. He's actually a lot shorter than you think. His feet don't reach the floor. He is wearing a top hat. Okay, so there's Freud. And in his insight-oriented treatment, it's all about making the unconscious conscious. That is his sole goal. That's all he wants to achieve, is make the unconscious conscious. He wants to look at unconscious conflicts, sexual or aggressive motives and impulses. He wants to help you identify and start breaking down your use of defense mechanisms. Okay? If you're always doing rationalization or if you're always doing displacement, we need to identify that, understand why you're using those defense mechanisms. Again, with a goal of achieving insight. That's what it's all about, right? So this should make you think of, when we did the section on personality, right? All this unconscious stuff was within this iceberg model, the stuff that's underneath the waterline, right? This is the level of conscious awareness up top. And so effectively his treatment is all about pulling up, dredging up this unconscious material and making you conscious of it. Okay? All of these things that kind of make you tick, if we bring them to the surface and help you analyze what's going on there, you'll gain some insight. You'll have that aha moment, the light bulb goes off over your head, and now you understand what's going on, why you feel the way that you feel. So how the heck do you do that? How do you dredge this stuff up? He has probably a half dozen or more techniques that we could talk about. I just pulled in 3 here to give you a sense of kind of the flavor of this treatment approach. So he might have you come in, lie on the sofa there, and do free association. Okay, so what's that going to be? Well, free association is, as the name would suggest, where you just freely associate, you just think out loud. Okay, in an unedited way, in an unedited form, whatever might come to mind, just speak it. Okay, even if it might be construed as offensive to someone or doesn't sound like a particularly nice thing to say about someone else, it doesn't matter. Just think aloud. Okay, so you might be free associating and thinking about, you know, your week at work this week and what it was like to interact with your coworkers and these customers, and you might start blasting some customer and say, she really reminded me of my aunt when I was a kid growing up. She was such a whatever, and you just free associating, right? Right out loud. Okay? Freud will help you make connections. He'll help you identify the unconscious material that's arising as you do that free association. Another very common technique that Freud used was dream analysis, right? So we did a whole little segment on his psychoanalytic approach to dreams, right? So he said that there was manifest content. Remember that? Or that was the story. So I had this dream and I was going somewhere with my friends and blah, blah, blah. Here's what happened. And then we said there was latent content, or the hidden meaning of the dream, what the symbols in the dream represent about the real world. So I want to analyze those dreams. Why? Because the dreams are filled with unconscious content. I want to bring that unconscious material up to the surface. Let's work on the dreams. Freud said dreams are the royal road to the unconscious. Best way to get at this kind of unconscious material. So he might do that. Finally, he might do an analysis of a transference reaction. So this is actually the most complicated of the three to get your head around. So let me explain to you what transference is, and then we'll talk about how you would analyze it. Transference is this kind of a scenario. It's when the patient transfers onto Freud concerns, issues, conflicts, stuff from other relationships. So that's what transference is. And then what Freud's going to do is analyze those transference reactions that the patient is having. So what would this be like? It would be something like this. If the patient is lying there and saying, you know, here's what was going on this week, and Freud says a couple of things, and then the patient talks some more, and Freud doesn't say anything, and the patient's like, you know, you're really starting to remind me of my father. I'm just making this up. This would be so easy if somebody gave this to Freud, right? You're reminding me of my father. Oh, wow. Now here we go, right? Because I'm not doing anything to act like your dad in any way, but you're transferring on to me those issues. Now we've got some good, meaty, unconscious stuff. You're probably not aware of the fact that you do this transference thing maybe onto multiple male models in your life, right? Your boss, right? Your roommate, your uncle, whatever, right? Where you have this kind of transference reaction, and now you're doing it onto the psychoanalyst here, okay? Freud would run with that and help you analyze those reactions, again, because they're giving us unconscious material here, okay? As you might suspect, doing this work is labor-intensive. It's a laborious process. In classic psychoanalysis, typically folks would come in and do 3 to 5 days per week of treatment for like 3 to 5 years. Okay? Do you think there are any health insurance plans that cover that anymore? I could tell you there are none. No matter where you look, you're not going to find any that will pay for that level of treatment. So some of this psychoanalytic work has sort of dropped some of the emphasis on the real early childhood stuff and has become more present focused, partly because you're not going to be given the leeway to do that kind of intensive treatment for that long a period of time, unless you're super wealthy, right? If you're super wealthy and you're paying out of pocket, you could do this and you will buy several very nice cars for your psychoanalyst friend there. Yeah. Outcomes with this. If I were to summarize it, generally not as good as other outcomes. It's a costly, long, labor-intensive treatment. I'm not saying it doesn't work, but there are other kind of quicker ways to get things done, and we like quick because quick is usually cheaper, right? So we'll get to that in a bit. Actually, when we talk about treatment outcomes, we'll mention it as well. All right, any questions about Freud, what he might do with you in treatment? Let's contrast it with the next model. The next model is called client-centered therapy. It comes from Carl Rogers, who, again, along with Abraham Maslow, was one of our humanistic psychologists, right? In terms of their approach to personality, they took a humanistic approach. Remember, that was really different from Freud, right? That was this very positive, optimistic tone, right? This was about things like, people striving towards their goals, people trying to do self-actualization, this innate growth potential. So as much as anything, what you're going to feel here with this humanistic approach is it's almost like a spirit or a philosophy as much as anything. It's going to feel a little bit more slippery when we talk about techniques because it's not really about what you do. It's sort of the nature of the relationship and how you treat this other person. Okay? So the major thing that it emphasizes is actually this overall kind of supportive emotional climate. And the idea is something like this. It's almost like if you create this supportive emotional climate and you kind of make a place here for this person each week to come in where they're supported, they feel like they have someone who's on their side, there's a warmth and a connection and a level of collaboration that's unique in their lives, that will be enough for them to start feeling better. Okay? At the risk of sounding like a 3 a.m. infomercial, it's sort of like you're going to help them unleash the power within themselves. Right? There's all this good stuff in there, in people. Why? Because people are innately good, according to this humanistic approach. And so we're going to just kind of help you unlock that. Okay? The other thing that's kind of subtle here, and you have to really be paying attention to notice this, is that the client-centered therapists like Rogers, they don't call you a patient. What do they call you? A client. Okay, think about that for a second. Just in terms of kind of the power differentials in the relationship, right? When you come into Freud, he's the doctor and you're the patient. It's kind of like this, right? I'm going to fix you. You have these problems and I'm going to do something to fix you. What does the client feel like? Kind of a little more balanced, right? I mean, there still could be, you're the person hired to assist this client or work with this client. There's a little bit of that, but there's a much more kind of collaborative, kind of equal tone to the relationship that I think is actually pretty important. In fact, and it bears itself out in the fact that as things proceed, it's not an issue of me coming in with an agenda each week as the client-centered therapist. I actually have a fairly easy job. When I come in each week, I'm going to let you determine where we go and how quickly we go there. And I'm going to play, again, this role of what I would call a facilitator, right? I've got some things in my mind that I think will help, but I'm not going to be prescriptive or kind of jam things down your throat and make you do certain activities or apply certain techniques each week, okay? That's the big thing here. The approach here with Rogers and these client-centered ideas is that it's very light on techniques. What you're providing is these three things down the bottom: genuineness, unconditional positive regard, empathy. I think really the only technique that kind of can be discerned if you were to watch a video of Rogers doing his thing is he does make pretty widespread use of what we call active listening. You guys ever heard of this? This is what I was kind of joking about. Remember back in the section on stress and coping? And I said in couples therapy, we've got to get the guy to stop trying to fix everything. Right? And the active listening in the context of this treatment is something that, in terms of a technique, it involves things like nodding. So you'll see this. And you'll see this and like, That's like I'm being really tricky. Nodding and It would be paraphrasing things that you've said. So you had a really tough week this week after you just described 5 or 6 different things. Yes, I did, blah, 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 blah. So some kind of summary of what you just said there. So paraphrasing and sort of lobbing, it's almost like I'm picturing like tennis where you're just lobbing back easy shots for the other person to return. Again, with an eye towards letting them determine where we're going to go and how quickly we're going to get there. So these things down the bottom are not like here's the technique and you do 1, 2, 3, 4 and then you're done doing it. They're much more slippery. So I can tell you what each is, but if it feels a little more difficult to get a good grasp of, I'm right there with you. Genuineness basically boils down to honesty. So this might, manifest itself maybe an example where, I don't know, you describe something that happened at work where one of your coworkers was really, really mean to another coworker, or maybe a customer who came into the store or something like that, and you were just totally taken aback at what they did and what they said. If I am expressing this genuineness as a client-centered therapist, I might say, wow, that just knocks me back for a second too. I can't believe that somebody would say something like that. So it's kind of some self-disclosure of how you're feeling, not in a weird, creepy way, but in a way that sort of, expresses this genuineness. Unconditional positive regard. If you have me pick what's really important down here, I'd say this is really important. Because this is sort of reflective of a relationship where you're not going to judge this other person. Basically, I think the best way to define unconditional positive regard is the Rogerian therapist or the client-centered therapist tries to express a significant level of acceptance. Right? I accept you for who you are just because you're a human being. And even if you say things or do things that maybe I don't necessarily agree with, I still value you. Why? Because this whole philosophy is about how good people are innately. Okay? So we're going to accept you even if you say that you did something mean, okay, or something that would be offensive or something. And then empathy. This is a tricky one. Empathy is really sort of a two-pronged thing. As the person is relating, let's say something really painful and she's getting teary as she describes it, it's a really emotional thing. What you want to express with empathy is, number one, I understand how you feel. And then number two, your feeling that way makes perfect sense. But you can't just say it that way. You can't just say, I understand how you feel. And feeling sad makes perfect sense. Right? That's not going to be particularly well received. So it's actually via the active listening technique that you could do that pretty well. Okay? The nodding, the facial connection, the facial expressions and the eye contact and those kinds of subtle things are nice ways of getting that message across. Again, I understand how you feel, and of course, how could you feel otherwise, right? Of course you're sad or angry or hurt about what you just described. That makes total sense. Okay, I'm right there with you. All right, questions about Rogers' approach. Is that like a warm, fuzzy kind of feel versus Freud? Freud feels kind of weird to me, like, oh, you want me to talk about my childhood and these weird sexual impulses and how I want to punch my boss in the head? And this guy's just like, oh, it's nice to meet you. What are you striving towards? I want to be your facilitator here. It's a different kind of warmer feel. All right, let's talk about cognitive therapy. Aaron Beck, who is a bow tie wearing guy, is somebody who emphasizes the need to recognize and change negative thoughts, sometimes referred to as stinking thinking. That the stinking thinking, the negative thoughts, get in the way and they make you feel sad, they make you feel depressed, they cause you problems, right? Think about Charlie Brown just last week. Sees these people interacting, assumes they're saying bad things about him, and now he feels terrible. Come on, Chuck, why are you doing that, right? We can utilize Beck's cognitive techniques with a broad range of behavior. You got cognitive elements for sure in depression. We mentioned cognitive elements in anxiety, right? Remember that idea of scanning for threats? Thinking about what could go wrong? We got to get you to stop worrying about everything that could go wrong, because what you worry about are things that are very, very unlikely to happen. Okay? You can use cognitive techniques with somebody with a substance use problem. There are huge cognitive variables that contribute to the maintenance of substance use problems. If you want to be really simple, there are expectancies about what the drinking or the drug use is going to do for you that are usually not in balance with reality, right? So very often somebody with a drug or alcohol problem will say things like, I can control it. Or if I drink or use the drugs, nobody's going to know. Okay? When you challenge that thought, you end up sort of holding up a mirror that says, you said, I can control it. Any evidence that you have ever been able to control it? Well, no. Okay? Nobody's going to know. The last time you went on a bender, how many people found out? My entire apartment complex, Everybody at work. Okay, so the evidence is just not there. So Beck says the way to try to work with somebody in cognitive therapy, it's basically a little three-step process. And it has a catchy way of being summarized here. What you're going to do is help the person, number one, catch it. And by it, I mean the negative thinking. Number two, check it. I'll explain to you what that means in a second. And then number three, change it. Okay? Real easy to remember this. Catch it, check it, change it. I love this stuff. So what's this about? This was the stuff I could train on grad school, by the way. So what do? You catch it. You basically help the person start to identify the negative thoughts that are causing them problems. Okay? The one I used last week was the all or nothing thinking in the form of, you say, I always mess everything up, I never do anything right. Those are actually two thoughts there. I always mess everything up, I never do anything right. Let's catch that, and part of catching it is identifying how do those thoughts affect mood. How do you feel when you say to yourself, I always mess everything up, I never do anything right? Well, my level of depression, the patient might say, is like an 80 when I think that. So those thoughts are not helpful. They're causing you big problems. So what can we do? We can check those thoughts. And checking it means looking for evidence that either supports or doesn't support the thought. Okay? So you just said, I always mess everything up. I never do anything right. So what would be contrary evidence that we could try to check for? Examples when you did what? Something right. Right? Is there any evidence anywhere in the past week where you did something right? You're like, no, there's nothing. What I would do as a therapist then is say, you know what? There is one thing. You came to the appointment today. Oh, yeah, well. Right? That's one thing. So we start chipping away at it so we can find evidence that's contrary to usually these very skewed, very negative thoughts. And then change it involves coming up with an alternative thought. Okay, I'm going to do this stupid balance beam thing, right? The thinking in somebody who's depressed or anxious usually is really skewed like this, okay? Cognitive therapy doesn't say, oh, just think happy thoughts and you'll be fine, because that's annoying and it's dismissive and that doesn't help, right? So what we're trying to get the person to do is balance it out. Get like this rather than totally skewed to the negative. So what we want in terms of changing it is we want them to generate alternative thoughts like, sometimes I mess things up, but sometimes I do okay. Now, that's a very different thought, right? Think about the effect of that thought on your mood, your level of depression, right? The other one was, I'd never do anything right, I always mess everything up. I felt depressed at a level of like 80. If instead I think, sometimes I mess things up and sometimes I'm okay, maybe the depression is, I don't know, 30 or 40 something, but definitely better than where I was before. Usually what Beck will do is then combine that with other kinds of behavioral interventions, the CBT thing that I alluded to before. Okay? What's CBT? Cognitive behavioral therapy. So behavioral elements for treating depression are really, really simple. All you're going to do with the behavioral piece for treating depression is you're going to have them go in and plan out and do pleasant activities. Because if you remember symptom number 2 on the symptom checklist, it was a diminished interest in or pleasure in activities. They stop doing fun things. You know what the treatment is? Do fun things. It's really, really straightforward, right? Schedule them in, and then you have them track things like their depression level as a function of doing that activity. Okay? You can do some interesting things with that. Let me talk about behavior therapy and Volpe, and then we'll take a look at Stephanie's video of her treatment. Joseph Volpe is a behavior therapist who cares not a whit for insight. He cares all about action. He has an approach to treating phobias that's called systematic desensitization, which involves making you less anxious in the face of your phobic stimulus by exposing you to the stimulus and then doing something called counter-conditioning. Okay, so what's this? Exposure means just go and face the thing that you're afraid of. So you're really afraid of spiders? You know what? We're going to face our fears. We're going to expose ourselves to the spiders. Why? Because this is going to directly address the huge issue of avoidance. We talked about this previously in here, right? One of the big things that maintains your fears when you're somebody who's prone to anxiety is all you do is avoid, 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 avoid. Right? Remember we said when you cancel the dentist appointment, how good you feel because you're so afraid of going to the dentist. Okay, we got to get you to expose yourself. No, that sounds weird, to expose yourself. Now, I don't mean flashing someone. Facing the things that you're afraid of. Okay, we're going to break the connection between what is effectively a conditioned stimulus in the context of your phobia and your conditioned response, which is automatic anxiety responses to that feared CS. The CS could be snakes, it could be spiders, it could be heights, whatever it is. It could be airplanes. I'll show you on the next slide some exposure-based treatment for fear of flying. Okay. Effectively, what we're going to do is replace your anxiety response with a relaxation conditioned response. So what you usually do in the face of the spiders or the snakes is you get really, really tense and you have lots of physiological responses that are indicative of anxiety. What we're going to do instead is have you come down here and do relaxation instead. By the way, the reason this works so well is something called reciprocal inhibition, which is a term you don't need to know. But reciprocal inhibition is how you're built. Remember your autonomic nervous system, which had sympathetic and parasympathetic divisions? You guys remember that? Sympathetic is anxiety, fight, or flight. What's parasympathetic? Relaxation. You can't have both of those systems turned on simultaneously. So if we can substitute in relaxation, that is parasympathetic, instead of anxiety, that is sympathetic, you're going to be off and running. Okay? Usually what Volpe does in doing this treatment is he does 3 steps. You can see a lot of 3-step ideas here with these cognitive behavioral treatments. First thing he does is relaxation training. He basically teaches you how to relax. Okay? So you will learn how to do progressive muscle relaxation, some kind of imagery-based relaxation technique, whatever the specifics might be. You learn how to physically get relaxed. Okay? He'll probably do that for a session, no more than that. Then he's going to help you build an anxiety hierarchy. This is awesome, and I'll show you an example of this in a bit on PsychPortal. What's the anxiety hierarchy? It is a list of increasingly anxiety-provoking situations related to your feared stimulus. Okay? So if it is snakes here on the slide, it starts with at a level of, let's say, 0 to 100. A 10 is reading the word snakes. A 25 is a picture of a snake. A 45 is a video of a snake. A 65 is a fake rubber snake. A 75 is a real snake in a cage. An 85 is a real snake on somebody else's arm, and a 100 is a snake crawling up your arm. You see it? Right? As you go up the hierarchy, it gets more and more and more anxiety-provoking. The final step in the treatment then is exposure with relaxation substituted in. Exposure with relaxation. Basically, what we do is we work our way up the hierarchy from the bottom, and at each step, so now you're looking at the rubber snake. Okay? Once you start feeling some tension and some anxiety, we stop. And you do the breathing, you do the muscle tension relaxation, the progressive muscle relaxation, and you're off and running now with a new response versus what you typically had done before. Okay? Behavior therapy always involves exposure, so here is what's called an in vivo exposure if somebody's afraid of flying. This is actually really cool here. Here's a virtual reality exposure for fear of flying, and this is one of the best Far Side cartoon comics ever. Professor Gallagher and his controversial technique of simultaneously confronting what? The fear of heights, snakes, and the dark. You're up high, it's dark, and it's filled with snakes. That's just awesome. All right. I want to show you the exposure-based treatment for Stephanie. And then after we watch the Stephanie video, I'm going to give you a little quiz about what we've done today. So let me bounce out of this. Remember, Stephanie was having all that trouble last week with OCD. So let's go on the helpful videos link here and scroll down to the treatment section. And we're going to see exposure response prevention. What was she really, really afraid of? Germs. So what are we going to expose her to? And then what response are we going to prevent? The hand washing. So check it out. And you'll continue to see the deviance, the distress and the dysfunction in this week's video too.
Stephanie's fear of contamination has colonized every aspect of her life. Her whole house is subject to a decontamination ritual as strict as the one she uses on herself.
Here's the deviance, right?
I have to clean in a certain way, and I start at the front door and I work backward. Once I start cleaning, I can't stop, and I have to decontaminate in the perfect way. Like nothing can go wrong. If it does, the contamination jumps to something else. It's really frightening when something gets contaminated. It's only a matter of time before it takes over everything.
So here's the beginning of treatment.
Stephanie's starting her therapy. She's been taking Prozac, which often helps OCD, but it hasn't been enough. Dr. Yadin has come to begin cognitive behavioral therapy. Today, Stephanie's going to bring in the mail, which she hasn't done for a year.
Why won't she bring in the mail?
So how nervous is this make?
It's got germs on it.
It's 40.
It's got cooties. People lick it.
30.
Gross.
Slow. Excellent.
So you're going to hear her repeatedly giving numbers, rating from 0 to 100 how anxious she is.
For Stephanie, who has a terror of contamination from bodily fluids, the thought of handling envelopes, which someone might have licked shut, is particularly repugnant.
Is recognizable.
The idea is to expose Stephanie to situations that cause her anxiety, but then prevent her from doing the compulsive cleaning rituals she normally would do to contain it.
So exposure and response prevention. Now she's at 40 on the anxiety scale.
Just pounce on. Be too careful. Good. Excellent. All right. And now that you've done this, hands are contaminated. Is it difficult? How difficult? 50. At 50? That's okay. You can tolerate it. It's all right. Remember I told you it's going to be very difficult for you. Okay. What could you touch? I mean, touching Jake would be too hard for you right now, would it? Okay. What can you touch that's not that hard? The couch. You could touch the back of the couch.
The back of the couch.
So let's do that. Ready? Good. And when you do it, I would like you to touch the couch everywhere. Okay. I know it's hard for you. Okay. Can I do some help with the anxiety?
Can you touch the couch?
Yes, absolutely. Touch it. Okay.
Stephanie's
What's going on? She's exposing herself now to these germs.
wants to spread the contamination around.
That's very difficult for you, but it's better. It is better already? Good. You know, the anticipation usually makes it worse. So you want to pounce on it as fast as you can. So you see what happens is, and the reason it's called exposures is it's the things you've been avoiding, and you don't get a chance to test. You're very courageous already. You might as well capitalize on it.
Here we go.
Stephanie has suspected alien germs she imagines are on the letter all over the couch.
I'm going to move so that you can do it.
Spreading those nail germs everywhere. And now she's going to be dying to wash her hands, right?
Infecting the couch is one thing, but can Stephanie go one stage further and expose her son Jake to the germs?
Good. I like the energy that you're showing going towards you angry at the OCD. Good. I like that. I want you to be angry at the OCD, not at yourself. Okay? I'm angry at the OCD too. It's ruining your life. I want both to be able to.
I can handle Jake.
You can?
Yeah.
Let's do it.
Come here, honey. Oh, well, maybe not.
She's worried about giving Jake germs, right? He's got his hands in his mouth. He probably just touched the cat's butt, you know. Jake's got the germs covered. Stephanie, you're not going to do anything more that's going to make it worse. Jake is already just a pile of germs.
It's wonderful. It is okay. It's okay to do it. Yes, I'm positive. When we go to the higher items, I won't reassure you, but for the first time, absolutely. Good.
Put him on the couch.
Just hold him for a little while. Yeah, just hold him for a little while. Hi, Mommy. Hi, Mommy.
It's okay to put him on the couch.
It is okay to put him on the couch. It is. Because remember, you just touched. And you.
Okay.
And we're just doing an exposure.
No, I'm a bad mother if I do that.
You're asking me for reassurance? You okay? Okay.
Hey,
He
back
doesn't
off.
know me very well. Good. All right. How does it feel? What are your suds?
75% of people with OCD show some improvement with cognitive behavioral therapy.
Our experience with other people who have this kind of OCD, many of them will get a lot better by the end of treatment.
Feel free.
So 75% of them showing improvement. So it's a very effective treatment. The problem is that 75% success rate is for treatment completers. It's obviously not a fun treatment to do, right? If you're the patient with the OCD, this is a difficult treatment for you to actually face up and do. All right, let's do a little quiz here at the end, since we haven't done one of these in a while. The SSRIs, such as Prozac, Paxil, and Zoloft, what do they do? Do they increase the release of serotonin into the synapse? Do they increase postsynaptic sensitivity to serotonin? Do they limit the reuptake of serotonin in the synapse? Or are they used to treat schizophrenia? Choose one of those four. We're going to do 3 questions. And please, on the last question, don't just respond and run out the door. Just wait. We'll be done like right at 10:45. All right? There's nothing more exciting than the questions we're doing right now. All right, so this is the medication question. Did you get that? Yes, you did. Very good. So they limit the reuptake. Why? They're called selective serotonin reuptake inhibitors. Awesome. Next question. ECT is found to be an effective treatment for what? Do we use that for eating disorders, anxiety disorders, schizophrenia, or severe depression? On Tuesday, we will finish up the treatment section. We'll talk about the treatment outcome research. As I mentioned on Tuesday, I've got a couple slides that talk about specific treatments for specific disorders that you aren't really technically responsible for the test, but I do feel like I would be doing you a disservice if I didn't give you a list like that that you can refer back to in the future if you needed to. All right, last couple seconds on this one. That's easy, right? I said if you're stuck and you're trying to guess one of the biomedical treatments, what it's used for, the answer is almost always going to be depression. Last one here. With which of these treatments does the therapist replace a fearful response with a relaxation response? Is that systematic desensitization, free association, aversive conditioning, or transference? And thank you for sitting until we're done. I appreciate it. So online on Tuesday, Thanksgiving next Thursday, online the Tuesday after Thanksgiving. 2 weeks from today, we're back in here doing test 4, and then we are done. And then I don't teach again until January 22nd, I think it is. That's a pretty good deal right there. It's going to go to 0 and there's going to be like a sprint out the door. Watch. All right. This is another big number. Yes. That's systematic desensitization. Have a great Thanksgiving. I'll see you online on Tuesday if you're there. See you back in here in 2 weeks.